All right, welcome back to the Hurwitz Lab. We've got again with us today the college-educated Dr. Alan Segal. He's not wearing his college sweatshirt today, so we're not sure, but I'm pretty sure. And we're excited today to keep going with our physiology discussions, and today we're going to talk about the topic of acid-base balance and that whole process. So I'm excited. Alan, welcome back to the Hurwitz Lab.
Well, it is great to be back in the Hurwitz Lab. You know, that's always, depending on what year it is, the Hurwitz Lab can take many forms. But I love this one. I was very happy with our last little chat and made us think about what the next topic should be. And acid-base is today's topic. And I think if you talk to medical students and residents and even fellows, acid-base is classically a difficult area.
Absolutely.
And my observation is that people find it very difficult because, you know, you and I have read a lot of the chapters on acid-base, and most of those texts and chapters are so esoteric that students give up and seek out shortcuts. Like, what's the equation, what's the picture, what's the shortcut? And maybe there's something on their phone that will help them. And I was once one of those students. I vividly recall being a third-year medical student on call in Chicago, sat down with both Cecil's and Harrison's textbook of medicine to read about renal tubule acidosis. Long chapter, written by the researchers who had pioneered the discoveries. And it was great for them, but it was terrible for us. And we didn't understand it. And I thought, it can't be this hard. And it turns out it isn't.
And I think one other thing for today and this whole series and everything we're doing is to try to get people excited about these topics, because you shouldn't. It's enjoyable. You got to love it, and you got to see it connect with how we use it in real life. And understanding these topics is fun. Right.
So you're right. You have to make it so that it's something fun to think about that you can apply at the bedside or the website.
Exactly. You got to use it at the website.
At the website. And so there is a simpler way. I think when you look for the shortcuts, you miss the foundations and you're not grounded. And so today what we're going to do is we're going to look at some of the fundamentals, and you're going to see how things fall out of that, I hope, and people have fun doing it. So I think we can actually start going.
All right,
to the
let
slides.
Me pull that up, and I'll let's see if we got that looking right. Yeah, it looks pretty good. I see your slide here.
Okay, and am I able to click on it? You think?
Yep.
Okay, so you know, Craig, you're not going to be surprised to find out that the starting point for all this is always steady state. So whether you're talking about fluid and electrolytes or whether you're talking about acid base,
or whether you're emailing Alan Segal.
That's right. Steady state is, people have to remember the definition is it's a rate. It's when the excretion rate equals the production rate. So in the little picture shown here, you see there's an input flow rate into the beaker that has a permeability. And as what will happen is at any given input rate, the level of steady state level in the container is going to be when the driving force and permeability are such that the flow in and the flow out are the same. So whether that's water intake and urine output, or whether it's protons, it's the same kind of thing. And I'll always remember that.
And this is nephrology in a single slide.
Right, it is. It's flow. Nephrology is flow, like so much of life is, and flow is determined by two things. Anything that moves, no matter what, if you're seeing something in the world move, that's because there's a driving force for it to move and a permeability. Last time we talked about, for example, how there's always a driving force for water reabsorption in the collecting duct, but the transport doesn't happen until the aquaporin channels are open, and then if they have the driving force and the permeability, you get the water reabsorption. So that's the starting point for everything. And then to make it more specific for acid base, I don't think I'm able to.
All right, let me get my mouse over there.
Get your mouse on there.
Of course. Hang on. There we go.
Okay.
Should be good.
Yeah. So here's basically how important I think steady state is. So we're born, and this line is the line of life. You're born, and if life goes perfectly well for you after a long enough time, 100 years or so, you'll live in this normal steady state, and then one day, a long time from now, you'll die. And that's the big difference, because when you die, you go to equilibrium for the first time. The whole idea of life is to live in steady state, which requires energy, and then one day, only once, go to equilibrium. Now, here's what happens to people. Somewhere along life, they can get injured. Injury is essentially acutely falling out of steady state. And so what we try to do, If it's acute, it's an inpatient admission. And our job is the red line is to get them back to normal steady state at discharge.
We're the clampers of life.
Exactly. Now, sometimes the injury is so bad that they'll end up with a chronic disease. So chronic disease does not mean that you're not in steady state. It just means you're not in a normal steady state. You're in an abnormal steady state like our dialysis patients are.
Right.
They're in steady state to the extent that we can do it, but it's an abnormal steady state, and it comes with it.
And we want it to be a survivable steady state.
Right. But usually whether you get there in that abnormal steady state, your life is not going to be as long as if you didn't have it. So if the injury is very serious, you might go to the ICU, where you can get very close to equilibrium, but hopefully that doesn't happen. And when that does happen, it's when physiology is not compatible with long-term survival, and it's sad. But when we can get you back, hopefully back to the normal steady state, or at least to there, but that's still going to mean you're going to die early. So there's 3 times to die. The one you want to avoid is that serious injury in the ICU early on. You want to also avoid the chronic illness steady state if you can, because you live the longest when you're in the normal steady state. Okay, so that's good for life. And then here's our dialysis patients. They're kind of in a pseudo. They're always getting them into the hospital, so I put them in there as sort of like it doesn't. They're never really. They're in a meta steady state.
Right.
So in terms of acid base, let's get right into that. Okay. In terms of acid base, let's make it simple. We are always staving off acidosis, and there's 2 kinds of acid loads that we have to deal with, respiratory and metabolic. So the first one is we're organisms, not all organisms are always staving off acidosis, but we are. So considering steady state, basically the acid base challenge is that our bodies produce CO2. And the reason that we develop lungs and what drives our ventilation is CO2. CO2 stores are linear, and it's actually bad when somebody goes on hypoxic drive. So when a lung disease patient goes on a hypoxic drive, that's not healthy. You want to be on a CO2 drive because that's really what's supposed to drive our respiration. And so a typical person will make 15,000 to 20,000 millimoles of CO2 a day, and they have to excrete that. And it's just the only way to stay in steady state is to excrete that. And it turns out that the driving force for that steady state to be achieved is what we know is the normal PCO2 of 40 millimeters of mercury. Now, again, if you think of 40 millimeters of mercury as just a number to remember, it's different than if you think about it as, that's the driving force. That's a driving force. It's a pressure. Okay. That's a driving force. And that is the driving force at which, what's special about that level is that's the part of the steady state where you have a normal permeability, that is alveolar surface area for gas exchange. Then you will be able to have the steady state of your excretion rate and your production rate, production rate being the same, and they will all center around the PCO2 of 40 millimeters of mercury. Now, lung disease leads to a loss of surface area, gas exchange usually. So it's emphysema or chronic bronchitis. Mm-hmm. Now, those patients, like our dialysis patients, can still maintain a steady state, but there's a cost. The cost of being able to still have that excretion rate be equal to the production rate is the driving force, or the PCO2 level has to go up. And that's why patients with chronic lung disease have chronic stable PCO2.
Right, and that's their beaker filling.
Exactly, right. Because they got hair in the drain.
That's it.
And when there's hair in the drain, you can still do it, but it's going to be at a higher level. Everybody who's had a hair in the drain sink knows that. So now if the CO2 excretion rate exceeds the production rate, that's our states of hyperventilation, and that's immediately gives us the acid-base abnormality, one of the 4 cardinal abnormalities of the primary respiratory alkalosis. It's as simple as that.
Right.
Now, the other kind of acid load we keep getting because we eat and metabolize is protons, and that's the metabolic. So proton excretion rate has to equal the proton production rate, and generally the proton production rate's a millimole of proton per kilogram per day. So let's just say 70. Okay. So the kidney, not the lung. The lung takes care of the volatile acid, and the kidney takes care of the mineral or the metabolic acid. The kidney must excrete these protons a day. So it doesn't sound like so hard to tell the kidney, hey, I got 70 milliequivalents of proton here. I'd like you to excrete it. Now, if you don't know anything, and you walk up to something and say, look, I got 70 millimoles of milliequivalents of proton here, that I need you to excrete. Even if you knew nothing about the kidney, what would you suggest would be the easiest way to do that? like, wouldn't it be great if the kidney just had a proton pump?
Right, a pump.
A pump.
Right.
Well,
pump it out.
It turns out, and here's the thing that gets lost in all the stuff that people get taught, it turns out that the kidney does exactly that. The kidney, of course, took the simplest way, and the kidney has proton ATPase pumps. It does it by the simplest mechanism. That's what the kidney always does what you want it to do. Now, kidney disease leads to a loss of the net capacity for proton pumping. This, again, is a problem with permeability, so to speak. And so patients with kidney disease can still live in steady state, but rather than having a bicarbonate concentration of 24 milliequivalents per liter with a normal, they might live at a steady state of 21. Right. That's the cost of having disease. And that, again, brings us to a second of the 4 cardinal abnormalities. That's a primary chronic metabolic acidosis. And on the other hand, if the H excretion, the proton excretion exceeds the production rate because you've got vomiting or hyperaldosteronism going on, and as I'm going to tell you later, vomiting is when you're secreting protons by throwing them up, and hyperaldosteronism is when you're secreting protons by throwing them down into the urine. And the result is primary metabolic alkalosis. So we'll talk a little bit more about those. But these are the fundamentals. So you can take this fundamental. This is just a fun slide of saying, somebody says, well, like a kid says, how many times do you have to breathe a day? How many breaths do I have to take a day? And the answer to that's easy to calculate, because if you know that you're supposed to stay at driving force of 40 millimeters of mercury, and you know the CO2 production rate, if you go through this slide, I won't go through it, but I mean, if you just read this slide, it uses the universal gas law and other things like that to show that the number of breaths required per day to maintain a PCO2 of 40 millimeters of mercury is that you would need about 19,000 breaths per day. And if you divide that by 1440, the number of minutes in a day, it says that you'd have to breathe 13 times a minute, and that's right in there. That's right in there with the normal. So people say, why did you breathe? You breathe to exhale CO2, and what comes along for the ride is you oxygenate.
Right, exactly.
But this is what you do, and 13 breaths a minute doesn't sound like much, but it adds up pretty quickly to 19,000 a day. And again, when you know that you're going to climb steps, your CO2 production is going to go up, but you don't start breathing hard until you start making the CO2, because the CO2 has been. It's only then that the rising CO2 level gets detected by your receptors. So I wanted to go back briefly to just some basic history that is not scary.
Right. But I think this is going to be critical for tying these two acid production systems, the management systems, the respiratory system, the metabolic system together in a simple equation.
Right. And what you're saying is, and I love it, is that really acid-base balance is determined by the interplay between the lungs and the kidney.
Exactly.
Okay. And what puts that together are these concepts. And because we live in an age where people have always heard about pH from the television or whatnot, people think pH has been around forever. But it turns out pH has only been around for a little over 110 years, because Sorensen, the great Dr. Sorensen, he invented the pH scale in 1909. And he was doing that because he was working for Carlsberg Beer. And his house had a pipe. It was right next to the factory. There was a beer pipe right next to his house. So he turned that permeability on, and he came up with the pH scale. And for our purposes, that's when pH was invented. And there's really nothing that takes the place of pH. So it would be a few years later, until 1932 or so, or 1934, when Arnold Beckman came up with the first electronic pH meter. But the only way to measure pH is with the meter.
Right. And we're talking about, just like before we've talked about the concentration of sodium or the concentration of water, we're talking about the concentration of protons.
Exactly.
That's it.
Exactly.
How do you measure it?
And you measure it with what turns out to be an ion-sensitive electrode.
There you go.
Which generates a voltage that gives you a signal.
Amazing.
And that voltage is turned into the signal that's determined by the following equations. So, the pH of the blood is of the ECF is 7.40. And the usual pH of the ICF inside the cell is 7.2. That's not a lot to remember. And the third pH to remember that may be important is that we as humans can lower our urine pH as low as 4.4. Now, if the urine pH is 4.4 and the blood pH is 7.4, that's 3. And 3 on a pH scale, a log scale, means that there's 1,000 to 1 gradient. So what the kidney can do amazingly, and we'll get back to this when we talk about renal tubular acidosis, what the kidney's membranes can amazingly do is you can stuff 1,000 protons in the urine for every one in the blood across that epithelium. And that is a huge capacity. And you'll see that to get an RTA, you actually have to lose 90% of that. And I think it's pretty reasonable to say if you've lost 90% of something, it's probably not normal.
Yeah, right. You're out of steady state.
You're out of steady state.
Well, you might be in it, but boy,
not a normal one.
No, that's not normal.
And the other concept to remember, not make too complicated, is buffers. So if you add a proton, a free proton, I mean, pH is the negative log of the free proton. So a free proton will change the pH a lot. So to prevent that from happening, there needs to be buffers. So otherwise, you're going to be banging around all these pHs every time you get a load of acid.
And one minor change, this is a log scale. So like you said, it's like a minor change in pH going from 7.4 to 7.2.
Huge.
Is a huge change.
Right. So the three buffers I would tell people to sort of keep in mind is that the ECF is its main buffer. We'll talk about bicarbonate buffer system. Intracellular buffers, the biggest one is hemoglobin for buffering protons. And in the urine, the one that's most important and regulatable, we'll talk about, is ammonium. Those are the three buffers to remember. There's a zillion buffers.
Right.
These are the ones that you want to keep in mind. And then once you've got these down, you can go and look at till your heart's content at all the other buffers. You remember from being in the lab that when you wanted to make a solution with a pH of 7.5, you would go on the shelf and you'd look for the buffer that had a pK near the desired pH.
Right.
And you found that Heppies, for example, is the buffer that its pK is 7.5. And that's why you made that. But the beaker didn't breathe, and that makes all the difference. So moving on to the bicarbonate buffer system of the ECF, the big equation that's presented in medical school, and it's true that you need that, is, and there should be a double arrow for some reason that came off wrong. CO2 plus water going back and forth to form carbonic acid, which goes back and forth to form proton and bicarbonate. So one little game I like to sometimes play with a student is to say if somebody's walking around with the perfect PCO2 and a perfect bicarbonate and they're perfectly healthy and they drop and stop breathing, and it takes you a minute to get to them, what will their pH be, and what will their PCO2 be, and what will their bicarbonate be? And so the students are very good at saying that the pH will be lower, and the reason the pH will be lower is because the CO2 has gone up because you've stopped excreting it. But then it's interesting when they say what happened. So then they'll say that, and they'll say, okay, so since the pH is lower, the bicarbonate must have gone down. Well, this equation shows you
that the protons went up.
Yeah,
because CO2 went up and this equation shifted to the right.
Right. So protons went up, which brought your pH down. But the bicarbonate, when you find somebody who's in cardiac arrest shortly thereafter, even though their pH may be 7.2 or 7.1 and their PCO2 may be 80, their bicarbonate, if it was 24, is now 25 or 25 and a half because of this reaction. And this reaction is catalyzed by carbonic anhydrase, which is important.
Our friend in the kidney.
It's a friend in the kidney, for at least 4 isoforms. And then, interestingly, people wonder, why did nature pick the bicarbonate buffer system? Because 6.1 is the pK for the system, which is not close to 7.4, but the reason is the greatest reason you can have. When you have the Heppies, you want to be close, it doesn't breathe. But when you have an open system like us, the fact that we breathe allows that 6.1 bicarbonate buffer system to work for a pH of 7.4.
Got it.
And that brings us to what your favorite thing is, of course, and that is talking about your
two best friends.
Your two best friends, Craig. Henderson and Hasselbalch.
Gotta love them.
Or as what we used to do, I think back in the day, didn't we come up with something with Henderson without the hassle, the hassle? People often spell Hasselbalch, but it's not.
Right.
And the reason it's a hassle for them is because students generally don't like logarithms. If you don't like logarithms, don't expect to be friends with Nernst, and don't expect to be friends with Hasselbalch.
Oh, that's funny.
Because they needed it. Or Sorensen.
Or Le Chatelier.
So again, if you look what Henderson did, shortly after Sorensen came up with the pH scales, it developed the Henderson equation, which says that the protons in nanoequivalents per liter are equal to 24 times the PCO2 over the bicarbonate. And what that tells you is, again, if you look at that, the numerator is the lung, and it's fast because we can change our respirations fast. And the kidney is on the denominator, and it's slow. But that's your respiratory and metabolic. So if you look at the Henderson equation, if your PCO2 is 40 and your bicarbonate is 24, the proton is 40 nanoequivalents per liter, and that is the normal free proton, 7.4. But one thing that screws people up is the pH scale is very convenient, but it goes the wrong way, kind of like the difference between golf and bowling. In bowling, the high score wins. In golf, the low score wins. It is more acid. More acid means a lower number pH.
Correct.
And that's hard for people. So pH decreases or it becomes more acid as the PCO2 goes up or as the bicarbonate decreases. And the bicarbonate decreasing is the same thing as the proton increasing. Right. Now, Hasselbalch came along and put together the Sorensen and the Henderson to say, well, what would the equation for pH be? And he just derived the log form using the pKa. Mm-hmm. And those right there are the two forms of the Henderson-Hasselbalch equation. pH is either, depending on what you like, either plus the log of the kidney over the lung, mm-hmm. or minus the log of the lung over the kidney, depending on just what you want to do. And since it doesn't matter anymore because your phone's going to do it for you anyway.
Right, exactly.
But just to show you that it checks out, if we plug in the numbers on the bottom line there, 6.1 is the pK, 24 is the bicarbonate, 0.03 times 40 is 1.2. The log to the scale of 10 of that is 1.3. So 6.1 plus 1.3 equals 7.4. And that's the Henderson-Hasselbalch. And this is as bad as it gets. The rest of it, we're done with the equations. The rest of it is straightforward. And these, again, I want to stress, these fundamental principles that we talked over the last few minutes is all you really need,
right,
to do it. So the one other thing that people invented that I'll mention now is the anion gap. And the anion gap is just the difference between cations and anions.
And I think this also is that your ions have to stay in a steady state, just like any other, like the sodium balance. I mean, you have to have a steady state of ions, and so there is a steady state for your cations and your anions.
Exactly. So when people looked at the most commonly measured blood test that we get, they decided to leave off the potassium, and they said the anion gap, even though, of course, potassium's a cation, mm-hmm. the convention became, and most people still use, the anion gap definition of the anion gap is the sodium concentration on the electrolytes minus the sum of the chloride plus bicarbonate. Mm-hmm. And the normal anion gap is 12 plus or minus 4. It's just what it turns out to be, and different hospitals have different numbers. UVM, we studied this actually, and the average anion gap, the average normal anion gap was 11.2. But 12 plus or minus 4 is okay, because you're going to see that the important thing in the differential diagnosis of metabolic acidosis is we divide them into normal anion gap and increased anion gap. So the question is, what do you feel is an increased anion gap? Well,
right, yeah.
You got to use something. So I consider...
And now, since it's reported in most patients, you usually have a baseline anion gap for that person.
Exactly.
And so that's the key.
You see, that's an excellent point. You don't need to worry about the population's normal if you know the patient's history is normal.
Exactly.
Okay? I mean,
what was their steady state before the acute illness?
Right. So if I just use average handsomeness to mm-hmm. apply to me, intensely and extremely handsome, that's not going to be helpful.
Right.
So you want to use the person's own thing. So what are the things so the reason in the old days when the anion gap was thought up, we couldn't measure a whole lot of things. The gap only goes up because acids and anions get added to the body that we don't measure. Now we can measure a lot of those. So the elevated anion gap occurs in some forms of metabolic acidosis we'll go over. It results from the titration of bicarbonate by protons from an unmeasured organic acid like lactate or ketones entering the body. Mm-hmm. And again, when it was invented, we just couldn't measure those. Now we can, of course, measure lactate and ketones. And again,
but even things like albumin and
yes,
like
that
negatively charged
proteins
impact the gap.
That's right. And I'll show you a program that takes this all into consideration.
Awesome.
That's very easy.
Of course you will.
And then the urine
and then I'll make a button for it.
You'll make a button. And the urine anion gap is another anion gap that we use, which could be useful in the differential diagnosis of the renal tubule acidosis. So let's look at the disorders. So disorders of PCO2, of course, that the lung is pulmonary ventilation. We've already gone over this. The most common disturbances are somehow or other there's a defect in CO2 excretion. And what are those clinical disorders? Well, hair in the drain. Right. Hair in the drain, when it comes to the lung, is going to cause a respiratory acidosis, and the typical suspects are chronic obstructive lung disease. Now, you can also have excess CO2 excretion. The primary pulmonary process, which leads to respiratory alkalosis, like a person having an acute asthma attack. They're short of breath, but they're over-breathing and they're hyperventilating. A pulmonary embolism is a bad thing. Yeah. But again, the classic presentation is with a respiratory alkalosis. Sepsis can be a respiratory alkalosis. The most common cause in all of us is anxiety, and so our job, is nobody wants to see a nephrologist.
True.
You know every day, 16,000 times a day, you walk into a room and there's a scared person.
Except my wife. She likes seeing a nephrologist.
Exactly. But when the patients are seeing us for the first time, one of the things in terms of bedside manner is to understand that those patients are first and foremost have forgotten their name. They're so scared. And our job is to go in first and make them not scared. Because it's scary to see a nephrologist. Most people never heard the word before.
Absolutely.
And so anxiety is a big cause. And that's the old breathing into a paper bag you see on television. Now, the metabolic disorders of total CO2 or bicarbonate, depending on what you are, this is regulated by the kidney excretion of proton. The normal is 25. The most common disturbances, easy. Well, either the pump's working like it should or it's not. So if there's a defect in proton excretion, then that's going to lead to a metabolic acidosis, and that's when we're going to get into the renal tubule acidosis, carbonic anhydrase inhibitors, which are essentially proximal renal tubule acidosis in a bottle, and kidney disease. Then there are things that will increase renal proton secretion. As I mentioned, you can be throwing up protons, secreting them from your gut, or you could be throwing them down into your urine, and that will cause a metabolic alkalosis, and that's it's usually states of chloride depletion. Again, people talk about contraction alkalosis. I'm not a contraction alkalosis person. Again, if you've ever seen somebody with terrible diarrhea, they're very contracted, but they don't have metabolic alkalosis. So it's not contraction doesn't give you alkalosis. What gives you alkalosis is chloride depletion. And what gives you chloride depletion often is volume contraction. Right. But it's the chloride depletion, and we'll see the cell diagrams of why. But the combination of chloride depletion from diuretics or hyperaldo, or over-secreting protons via the proton pump is going to give you the metabolic alkalosis. So already we've covered all four cardinal abnormalities, okay? And then, again, you can not only lose from your gut, you can lose from the GI tract. So vomiting is throwing up, chloride depletion. RNG suction is chloride depletion and throwing up as opposed to the chloride depletion and throwing down. And then, of course, losing bicarbonate from the lower gut is equivalent to gaining a proton. And so diarrhea or laxative abuse will cause a metabolic acidosis. So those are the main disturbances. Now, there's long lists you can see in chapters. I mean, I wrote the chapter in Comprehensive Nephrology, the current edition of that gigantic textbook. I wrote the metabolic alkalosis chapter. And literally, if you want to read about that, you'll ad nauseum, pun intended about the vomiting, you'll ad nauseum see the causes.
And I think it also, from the GI standpoint, it's important to comment on, in the GI system, the pH can get very low because in the stomach, you can be what, to one to two pH. Yeah. I mean,
Right. And so the so-called ligament of Treitz.
So if you're NG suctioning that number of protons, you are really depleting the system quickly.
Yes, you're depleting them not only of proton, but of chloride. Right. Because the stomach's pH is 1 because of HCl.
Right, which is a strong acid.
Very strong acid.
That is 100% protons and chloride.
Yeah, that's the premium stuff.
Premium.
And when you're removing proton HCl from the stomach, that is the recipe.
And it seems like that is one of the reasons that vomiting and NG suction can be such a potent driver of metabolic
absolutely,
alkalosis.
absolutely. But all metabolic alkalosis, for the most part, is got the involvement of the loss of proton and chloride, and in the case of vomiting, the volume. Vomiting is hypovolemic, hypokalemic metabolic alkalosis, and hyperaldosteronism is hypervolemic, hypokalemic metabolic alkalosis.
Correct.
So it's
the difference in the volume.
The volume can go either way.
Right.
But the chloride depletion and the proton depletion are the same direction.
Yeah.
So how do you now? This is where students would really like to know how. And you'll read plenty of papers about the
bench
clinical
to
approach.
website.
Yeah. and so people want to know. Well, how do you approach a patient with acid base? You have to remember just a couple of easy things. First of all, there are basically two tools that you should have. Some people disagree that you need both, but I think if you really want to define an acid base disorder, if it wasn't painful to get a blood gas, get it. An arterial blood specimen, because that's the only measure you're going to get of arterial bicarbonate.
Right.
Okay, and then venous electrolytes at the same time. Don't get them at different times. If you're going to get the blood gas, get them at the same time. Now, as opposed to oses, a person can have multiple oses, but you can only have one emia. So the first thing to do is determine the emia. So if your pH is below 7.38, you got an acidemia. If it's above 7.42, you got an alkalemia. You can only have one emia because your pH is going to be just a number.
Right.
Okay. Now, once you know the emia, what you know about the patient may have one oses or more than one oses. The one thing you know for sure is the first primary oses is in the same direction as the emia. So if the emia said acid, then the first primary process is going to be respiratory or metabolic acidosis.
Correct.
And the patient may or may not have a second process. So if acidemic, determine if the primary process is metabolic acidosis. That's easy. If the total CO2 is less than 24, or respiratory acidosis, the CO2 is greater than 40. If it's alkalemic, the same kind of numbers, but in the other direction. It's always good, and this works on the boards. For example, one board's tip. Whenever you get a set of electrolytes on the boards, they will not calculate the anion gap for you. That's on purpose.
Right.
So while you're panicking, while you have nothing better to do
and
than
it won't be borderline.
Yeah. Since there's nothing better to do while you're panicking, I always like to calculate the anion gap.
It calms you down.
And the chances are good that after you calculate the anion gap, you're not only going to be calmer, but the question is going to have to do with, did the person do that? So step 4 is to calculate the anion gap, as we talked about. And then the rules of thumb I'll show you in this Excel program that I have about determining whether something's acute or chronic, and then determine the causes and treat the underlying cause. So that's the clinical approach. There's the gap. We already talked about the numbers. And then what I want to show you here is the typical diagnoses of what gives you normal anion gap, which are the ones listed there, hyperchloremic by definition. And then I have a mnemonic, and I have a mnemonic actually for both of them. I'll show you. So this is the normal anion gap, my mnemonic. I've never seen this in the literature anywhere, but I came up with it one night, diuretics. Now, it really only is for carbonic anhydrase because diuretics usually give you metabolic alkalosis, but it's still my favorite because diarrhea is up top, and that diarrhea should be up top. And then the next couple are also gut things. And then the next most important is the renal tubular acidosis that we'll talk about, the 3 of them, cleverly labeled 1, 2, and 4.
Yes.
And then anything that blocks ENaC, like all those drugs listed, when you block sodium reabsorption,
block proton excretion.
Exactly. You prevent the lumen in the collecting duct from being as negative as it would be, and that's going to somehow interfere with the driving force for proton secretion. And then there's a couple other things there. Carbonic anhydrase is an important one. It's RTA in a bottle. And then sickle cell is on that list. And then here's Kussmaul or PP, because PP is what we think about. The anion gap going up in metabolic acidosis. So the top one is ketoacidosis, where the ketone bodies are present either in diabetic or alcoholic varieties. And then the rest of them, other main causes, kidney disease, salicylism, the ketosis of starvation, methanol, Tylenol toxicity, lactic acidosis.
DNL.
Yep. And antifreeze is a big one. And big-time rhabdomyolysis, or, propylene glycol, since it's used as a vehicle in Ativan drips and propofol. So that's the mnemonic.
Yeah.
I can never remember them.
Yeah.
That's the mnemonic. But you just have to keep in mind, look at what the unmeasured anions are. They're usually lactates and ketones. Mm-hmm. And so often nowadays we can measure that. So if you want to be sure that whether your anion gap is elevated from one of these things, just measure the lactates and ketones and see if the gap goes away. Okay, so here is the kidney card that a lot of us have and carry around because it's the Nomogram of the Henderson-Hasselbalch equation and also Davenport diagrams. And it basically shows you, the normal blue dot there is showing you a bicarbonate of 25 and a PCO2 of 40 at a pH of 7.4. That's where you want to be, and that little range there is the normal range. And then, you've got the respiratory disorders on both sides in red and the metabolic disorders on both sides in green. And then there's these little rules of thumb, I should say. And what students try to do, and I don't like this. So if a test giver wants to test people by seeing who remembered the rule of thumb factor.
Right.
That is useless.
Agree.
It's a useless piece of knowledge, especially now there's this thing I heard about called the interwebs, where you can actually look these things up. And so it's not keeping this in your mind. Who would trust that anyway?
Right.
So this at least is the physiology of it. And I wouldn't recommend memorizing. These are already in MedCalc for the most part. Some are, some aren't. But I'll show you a couple things here. Here's my program. So this is a page out of my Excel folder for everything kidney. And what you see here is in this first slide, in black is what you enter. So you see the pH of 7.40, the PCO2 of 40, and the rest of the normal electrolytes. And the green and the other numbers are the output. So you'll see it first calculates the anion gap and takes into consideration the albumin, tells you what the anion gap is, and it calculates from the Henderson-Hasselbalch equation the number of protons, the concentration of protons, which you see. So 39, what does it say, 39.81. 0.81, pretty close to 40. So these things work. And then what it does underneath is it shows you
the correct,
what would happen if
the appropriate responses.
Right, the appropriate responses, and it's all programmed in. And so the blue shows you the equations, and the numbers are the numbers. So I never have to worry. I take a blood gas and if I've got a blood gas and venous electrolytes, I plug in my numbers in black up top. Everything pops out, and then I've got some other things here telling me about the delta. That's not that important today, and also some things about RTA. And the part of the slide that's cut off is this next part, which there's the nomogram. So I can sort of check my work. There's the rest of the equations. And you can see for chronic and for simple and several different, sometimes there's a couple different equations that people have proposed. So they're all calculated there. And again, I'm happy to give this Excel program. I mean, not only am I happy to give it to people, I wrote a book, which is an electronic interactive textbook for the kidney. These are part of it.
We should get the. I mean, these are online and they're available through different websites like correction calculators and MD Calc and so.
But I can guarantee you, I've got some in here that are nowhere else.
But I think the point of this is that you have to understand these processes and which direction things go. But you don't need to memorize the correction factors. And when you're exhausted in the middle of the night, you want to plug some numbers in. You want to understand the physiology, but you want to then get a number. And then these numbers are important because they tell you if there's one or more oses going on.
Right. There's no doubt that the numbers are important, but you're exactly right. There's a way to get the numbers correct.
Right.
The important numbers, and here they are correct.
Right.
Not dependent on your sleep-deprived state.
Exactly.
And since you've already learned it when you were awake, even when you're tired, you know your principles, and now believe me, I don't even think when I see the numbers.
Who does long division anymore?
Well, but I'm saying here you have it, and these work. That's what these worksheets are for. I don't have to tell you.
Exactly.
You're the builder of worksheets,
right?
But the worksheet, the shortcut. But what happens to the students? They all too often will just go to these programs on their phone that give them numbers, and they don't know where it's coming from.
Yes, that's right.
And that's what the problem is.
Yeah. No, agree.
So again. What if there's more than one process going on? Well, the Excel spreadsheet will tell you if there's more than one process going on. So let's take an example. Here's a gas, 7.32 pH, PCO2 16, total CO2 of 8. So we know the pH is 7.32, so it's an acidemia. So that's obviously the primary thing has to be a primary metabolic acidosis. Is it simple or is it a respiratory? So here the program would use Winter's equation to predict the PCO2. Winter's equation is this, and notice the bicarbonate is from an arterial blood gas. The left side is the PCO2 from the arterial blood gas. The right side has to be from the arterial blood. You can't miss blood specimens. One or two. So this says that if the patient's PCO2 is between 18 and 22, there's no other respiratory disorder.
Appropriate response.
It's appropriate response. I don't like the word compensation.
Right.
Okay, I like to, like you said, secondary response. You've been well trained, and so you see here so you could say in this case the fact that it's 16, you could say well there's a little bit of a So this patient may have two things. They certainly have the primary metabolic acidosis from their diarrhea or whatever it is, and on top of that, their anxiety has maybe pushed their PCO2 down a little bit lower. Another example of this could be, this pH is too good for DKA. But it would be the same kind of thing. Those patients are anxious, and the lowest PCO2s I've ever seen in my life are young people presenting
who
with
can
DKA.
just blow.
Yeah, they can.
PCO2
I mean,
off,
the lowest I've ever seen is 8.
Yeah, I've seen below 10. Yeah.
Okay, and then it's hard with the partial pressures because there has to be some oxygen in there.
Right.
And so it's hard to get below 8. But I saw a case recently, somebody published of 5, PCO2 of 5 on the ASN forum, and I wrote a question, well, wow, that beats the record. What was going on? And they said, well, it wasn't my patient. Okay, so now that's everything about acid base. Now, so if you didn't care, so if you're a person that doesn't care about the kidney, we're done.
Now they're going to pass the boards.
Yeah.
Nephrology.
Yeah.
You want to go into nephrology. You want to pass these board questions on acidosis.
So in the last couple of minutes, I just want to spend time on how how the kidneys do this. And we had talked about talking about the RTAs.
And this is my favorite slide. Yes. Almost my favorite slide. Well, this is get to the channel.
This may be my favorite New England Journal picture of the kidney from 2009. It's a beautiful diagram, and it also shows I think it was had to do with also diuretics. So you see it's already got the labels of where carbonic anhydrase inhibitors work in the proximal tubule, the loop inhibitors obviously in the loop, the thiazides, and then the ones that work in the collecting duct. So let's take a quick look at this. So physiological prevention of metabolic acidosis is a 2-part strategy. First of all, you have to reclaim all the filtered bicarbonate. The first rule is if you want to win, you better break even. So other than sodium and chloride, the thing that's filtered most at the glomerulus that's going to go right into the urine is bicarbonate. Right. 180 liters a day with 24, 25 milliequivalents per liter. That's a lot of bicarbonates. I think it's about 4 boxes of baking soda, of Arm & Hammer. Mm-hmm. So you can't lose any of that. So in a normal day, I like to ask the students, in your life, how much bicarbonate have you excreted in your urine? And they'll say, some. I go, no, not unless you've been sick. Because really, you don't lose any bicarbonate. The kidney is too smart. Mm-hmm. So the kidney, before you're done with the proximal tubule, the kidney's got 80% of it back. I'll show you how. The thick limb does 15%, and the last little bit, 5% in the collecting. So there's normally, you excrete no bicarbonate.
Right. And the nephron works this way with everything. It's bulk, it's medium, and then it's fine-tuning at the end.
Exactly. Now, even if you reclaim all the filtered bicarbonate, what about the bicarbonate that got taken out by the pepperoni pizza that you ate and got combusted down to some protons? So you have to regenerate all that bicarbonate. So there's 2 things that we talk about in nephrology: reclamation of bicarbonate, which is the first process of keeping what you filter, and regeneration, meaning replacing what you lost. And the job of that part of the kidney is really done, it's done in the proximal tubule to some extent, but this is what made the alpha intercalated cell famous. And so these proton pumps, again, I'll use the baseball analogy. Hopefully people don't get lost with the baseball analogy. But in baseball, we have a pitcher and we have a catcher. If the pitcher pitches and there's no catcher, you get wild pitches. Okay? If the catcher's there but there's no pitcher, well, then there's no game. So the proton pumps are the pitchers. And who catches those protons? Buffers. Because as we said before, if there was not a buffer in the urine to catch the proton, the pH would drop so fast, you'd lose your driving force. Mm-hmm. The buffers are the catchers that buffer that proton, mitigating a change in pH and allowing the next proton to be secreted. Mm-hmm. So the most important are the titratable acids like phosphate, but then that's not so regulatable. And then the big one I'll show you, and is ammonia, which is regulatable. Right. So here's a nice little picture that shows
I think we wrote an abstract about this.
I think we did. And so the equation, again, is that, and it's not all showing up here for some reason, but the net acid excretion is the ammonium plus titratable acid minus the urine bicarbonate.
You want to hit the arrow one time and see if it?
I don't think that's it. Okay, I think it just screwed up. But anyway, in the little picture that shows bicarbonate, we were talking about this. You see 80% in the proximal tubule, 15% in the loop, and the rest along the collecting duct. So that's taken from a review from C. Jason from 6 years ago. Mm-hmm. Now, here is the important part of that paper. You see that under normal conditions, the left column there shows the blue part is titratable acid, phosphate, some sulfate, and the ammonia turning into ammonium is the other. But when you get an acid load, like you have big-time diarrhea, what gets revved up is ammoniogenesis. So you really have to be able to rev up ammoniogenesis because the kidney's going, look at the gut over there, wasting all that bicarbonate. Well, we got to keep that. We got to keep the sodium that's being lost, the potassium that's being lost, and the bicarbonate's being lost. So we got to secrete a lot of protons as the alpha intercalated cell. How am I going to do that? Right. We got to rev up ammoniogenesis, which starts in the proximal tubule, and that's the regulatable part. So failure to do this to the maximal optimal extent is a type 4 RTA. Right. So if people are saying, "Oh, type 4 RTA is so complicated,"
it's impaired ammoniogenesis.
It's impaired ammoniogenesis. Maybe you can rev up ammoniogenesis, but not as much as you should normally. Yeah, and we'll go over that. So here's the RTAs. You know, you said how long will it take you to talk about the RTAs? I said you do the RTAs in 3 slides. So proximal, of course, proximal is, even though it's first in the nephron, it's type 2 because it was discovered second. Proximal RTA, again, remember the rule: secrete a proton and reabsorb bicarbonate. To win, you have to break even. In proximal RTA, the proximal tubule is supposed to resorb 80% of the bicarbonate by the end. If it doesn't, for whatever reason, that's going to give you a proximal RTA and bicarbonaturia. So the causes can be genetic, Fanconi syndrome.
Classic.
Multiple myeloma is an important cause to look for in an adult because proximal RTAs are usually kids. If an adult's got a proximal RTA, you really, and this is on the boards, if the adult has, it'll give you a case, an adult's got RTA, and you got to know they're trying to tell you this guy's got myeloma. Right. So how does the proximal tubule do this? Here's a little cartoon. So here's the urine on the bottom and the blood on the top, and we got the major transporters. The apical membrane has the sodium proton exchanger, NHE3. The basolateral membrane has the sodium bicarbonate co-transporter and the famous pump. So sodium and bicarbonate gets filtered. The sodium jumps right onto the sodium proton exchanger. Then the sodium proton exchanger needs a proton. Where's the easiest place to get the proton? From water. It leaves a OH behind. So the proton goes out, meets with the bicarbonate, forms carbonic acid in the presence of carbonic anhydrase in the blush border, will immediately be turned into CO2 and water. Now the CO2 is nicely go right back into the cell, and it meets its old friend, the hydroxide left behind. There's another carbonic anhydrase that catalyzes that. Yep. And then you make a bicarbonate, and so that goes out the sodium bicarbonate co-transporter. So again, secrete a proton, reabsorb a bicarbonate. The way that we reabsorb, reclaim, and regenerate bicarbonate is by secreting a proton apically. So, and then of course, sodium is coupled to the transport of so many things.
Which is why we see all those things in the setting of Fanconi syndrome when this cell breaks down.
Exactly.
Right.
So when the membrane is either born unhappy, when the brush border is born unhappy, or the brush border gets unhappy in myeloma, it's the brush border.
Right.
And what's on there? Impaired proton.
Call Border Patrol.
Call Border Patrol, exactly, because you're going to have bicarbonaturia, phosphaturia, aminoaciduria, and glycosuria.
Correct.
And of course, this is now the famous. I'll let you take it from here. So why don't you say something about
SGLT2?
Go ahead.
No, go ahead. Not me.
No, go ahead. No, I think go ahead.
We were talking
you're clinically giving them.
Well, I think about how important SGLT2 inhibitors are in blocking that transport of glucose up and causing glycosuria. But there's these effects by these medicines that are not related to diabetic management.
Yeah.
That protect people, and it probably has to do with volume changes, blood pressure. And you're actually giving these to your patients right now. So many of us are. Correct.
We're trying to figure out ways to get them. And I read something astounding. I don't know if I believe it, but somebody said, recently when that big story of the pig kidney being tolerated when they attach it to a human for the first time in history, some people said, well, we might not need as many transplants in the future because some people are saying, I don't know if I believe it, that SGLT2 inhibitors can
stop the progression.
Yeah, or make them come to end stage 15 years later.
It's unbelievable.
Is it?
The impact we're seeing from the studies in these medicines are way beyond what we saw with ACE inhibitors and ARBs.
Exactly. So we were happy about that.
Right.
So
we were thrilled.
So now
2001, it was during my fellowship. It was like 3 presentations at once.
Yeah, and so this is the time to now say, if you're excited about SGLT2 inhibitors, it's time to go into nephrology.
You got it. That's what this whole podcast is about. Go into nephrology.
The ulterior motive. Okay, so anyway, let's look into that's the proximal tubule.
Who's not excited talking about this stuff right
now?
And
we're done with proximal tubule.
All right.
So here's the acid base, and of course, you may remember being in the lab when we cut open tubule. Of course, we cut open
salamander tubules.
Yeah. But here's a cut open mammalian, not human, but mammalian collecting duct. And what you easily see there is two different kinds of cell types. Cells that are kind of look like my head and cells that look like your head. And the ones that look like my head with one central cilium is the principal cell. And right next to it are intercalated cells with all the villi on them. And so the principal cell reabsorbs sodium and secretes K through ENaC and ROM-K respectively. Right. And the intercalated cells are the acid secreting or bicarbonate secreting drugs. So here's again the nephron. And if we just throw on my diagram of the collecting duct on the side, you'll see there's ENaC and ROM-K. And then in the alpha intercalated cell, you see again, there's a negative lumen because of ENaC. That's a driving force for potassium secretion. It's a driving force for proton secretion. Secrete a proton, reabsorb a bicarb. That's an alpha intercalating cell, and that's what it does. Mm-hmm. So that's now, I turned it right side up so you can see it.
Beautiful.
And you see that aldosterone works in, there's a mineralocorticoid receptor in both of those cells, promoting transport. So when aldosterone, so this tells you that if the aldosterone levels go up, you're going to hyperreabsorb sodium and cause hypertension. You're going to hyper-secrete potassium and cause hypokalemia, and you're going to get a metabolic alkalosis from the next cell over, and that's exactly the classic triad of hyperaldo state. Now, there's also a beta cell. In the beta cell, just shown on this slide, so the top is the principal cell, and then the alpha intercalate. The beta cell is essentially the alpha cell flipped over. So now, one of the reasons, people always wondered in my day as a fellow, what is it about metabolic alkalosis that why the kidney doesn't get rid of it? Is the kidney the villain because it doesn't get rid of the metabolic alkalosis? And this slide has the explanation because something that was discovered after I was a fellow called pendrin, which is the chloride bicarbonate antiporter on the beta intercalated cell at the bottom. You see, you need chloride for bicarbonate to be secreted because chloride has to be reabsorbed. Remember, the metabolic alkalemic state is chloride depletion state. When you're chloride depleted and volume depleted, there may not be enough chloride being delivered to the beta cell to get enough bicarbonate out, especially since aldo is causing more of it to be reabsorbed. So the thing that could fix metabolic alkalosis, so to speak, is pendrin. It's oriented to do it. But is there enough chloride in those metabolic alkalosis states to do it? And there isn't. So here's the type 1 distal RTA. And the rule's the same. Secrete a proton, reabsorb bicarbonate. So distal RTA, type 1, results from a decreased ability of the alpha cell to pump protons across the membrane to maintain the 1,000-to-1 proton gradient we talked about. Again, that 3 pH unit. Patients cannot lower their urine pH below 5.4. Now, this is just something that is in a textbook that says you got to think about RTA. If somebody's got a metabolic acidosis and their urine pH is not below 5.4, then it could be a type 1 RTA. The way I choose to think about that is 5.4 is 1 pH unit over 4.4. It changes it from 10 to the third, 1,000, to 10 to the second, 100. So that's the 90% loss of capacity. So it is a big deal when somebody has got a spontaneous metabolic acidosis and their urine is not maximally acidified. That's not what the kidney would want. Something's preventing the kidney.
And acidification happens in the distal tubule.
Yes.
And so if you have a proximal tubular defect, you didn't impair your ability to acidify.
That's right.
And
that's right.
Whereas
in the
it
steady
just
state,
tells you where the problem is.
Right. So in the proximal in proximal RTA, there'll be the initial bicarbonaturia.
Exactly.
But then the serum bicarbonate will drop to a point where the driving force is such that it can keep up again. And in the steady state, kids with Fanconi and people on carbonic anhydrase inhibitors, in the steady state, their urine will be acid. So it's type 1 where the pH is can't be dropped below 5.4, and that's very significant. Even though it just seems like a number 1, it's very significant because a 90% loss of capacity, either because the pitchers aren't pitching, and there are genetic defects where the V-ATPase proton pump is mutant and the pitchers aren't pitching. So there's 3 possibilities when you have this in the distal nephron. Pitchers aren't pitching, catchers aren't catching, or the ball comes back. So in type 1 RTA.
Oh, right. If you remember, like amphotericin B.
Exactly.
Right.
So if you've got genetic defect of the pitcher, that may be
that's proton
pump failure.
Right.
Now, the proton pump would be perfectly fine, but because holes poked in the membrane by an antifungal,
right,
like amphotericin, classic, as soon as the gradient tries to build up, and we know from putting amphotericin in our patch pipettes, it pokes holes. And so the protons go out, but they come back in.
Right.
They leak across the membrane. So both of those are type 1s. So whether you can call it type 1A, if the proton pump is the problem, you can call it type 1B if it's amphotericin. But they're both type 1s.
Right.
Now, when there's not enough catchers, they could have called that type 1C. They called it type 4.
Right.
Okay.
Right.
So, again, there's the antifungals. So that's type 1. Again, back to showing you the same kind of physiology. And then we're talking about hyperaldosteronism and pseudo-hyperaldosteronism. That's just a little list there of the year. But the hyporenin, hypoaldo state, and this, I just wanted to point out for Little syndrome, because again, Little syndrome is when there is no aldosterone, but because the ENaC is overactive, you get everything that looks like the aldosterone level side, pseudo hyperaldosteronism. I just wanted to throw that in there. But then here we're on to type 4. Now, again, we talked about having the pitcher and the membrane being good. So what if your pitchers are good and your membrane is good, but there's not enough catchers? This is type 4. Okay. Now, it doesn't, to me, I think about it as, is it a pitching problem? Is it a catching problem? Or is it a membrane problem? To me, those are it.
That is a great way to think about it.
Because that's physiology. That's really what's there.
Right.
Okay. It's not like you use a microscope and you see the type 1 listed there at the label. So to me, when I see a patient who has what looks like a distal RTA because they have acidosis and their urine pH is not below 5.4, I say, okay, let's first look at the drugs.
That's it.
Okay. If maybe that's a membrane problem. Let's look if they have a reason to be hyporenin and hypoaldo, like they have diabetes,
right,
or obstruction, or sickle cell. And so again, when you think about the physiology, pathophysiology, it should naturally, organically lead you into differential diagnosis. When that happens,
then you're understanding doing it right.
Yeah, you know you're doing
cell
it right.
function, yeah,
right.
physiology.
And you know, I don't remember. I remember type 1, type 2, and type 4 only because I've been through it so many times.
Right.
I don't recommend remembering that. I recommend understanding it's a pitcher, it's a catcher, or it's a membrane. Okay. So again, this is just a failure of ammoniogenesis. The most common cause is not that you can't rev up ammoniogenesis, but you just can't maximally do it.
Right. And
the causes, again, genetic, drugs. But the big ones, I mean, I remember being a med student, taking my nephrology and saying, I want to be just like this. And in my nephrology attending, a very famous person, actually in Chicago, said, I'm going to tell you right now the 6 top causes of type 4 RTA. And I'm ready for my 6 causes. He goes, obstruction.
That's right.
No, diabetes, and obstruction.
Oh, that's so funny.
And so
that sounds like an hour line.
So you really have to look at those 2 possibilities first. And then, we were also in Chicago where there was a lot of sickle disease. So we saw people with papillary necrosis and sickle cell disease. But the big ones for type 4 are diabetics and people that could be obstructed or people with sickle cell. But it's a failure to rev up ammonia. So that whole big chapter that I read as a kid, in Harrison's and Cecil's, could have been replaced by pitcher, catcher, membrane.
Awesome.
So here it is again. And then the urine anion gap comes in handy. What you do here is you take the urine sodium and potassium and chloride and you do this equation. So let's say somebody has diarrhea. Since they're volume depleted, their urine sodium will be low. Since they're potassium depleted from the diarrhea, the urine potassium will be low. And since they've lost bicarbonate in the gut, ammoniogenesis is going to be revved up, and you're going to see a big urine chloride.
Spike in chloride, and you can have a negative gap.
Ammonium chloride, and that's a negative gap. So that's one way to one way to distinguish between diarrhea and RTA is to look at the anion gap. In RTA, the anion gap will be positive. Now, another way that I found
in the urine.
Now, another way that I found that's actually useful for distinguishing whether a patient has diarrhea
or
RTA is I do this thing called I ask the patient.
Yeah, exactly. That's what I was going to say. Or you could ask the patient.
Yeah. Oh, yeah. So you could do it like we talked about with the sword and the Indy film.
Exactly.
You know, I mean, you can go and do the urine electrolyte, but if you took a good history,
right?
I mean, I would be embarrassed to be the person who's calculating the urine anion gap.
Even mixed, complicated acid-base disorders can be solved most of the time by the history.
Well, I think there's an old saying in medicine. It's at least 80% of diagnoses can be made by taking history alone.
Absolutely.
So none of what we do, no matter how many Excel sheets I make, the joy, I mean, the Excel sheet, as much as that fun that is, it's still below looking at a urine, and that's still below talking to a patient.
Correct.
Okay,
Got
and that's how you've been trained, and that's how you are anyway.
I love it.
But I think that's it. That's, you know. So the question is, here's my question. So if this little session here of going back to the fundamentals of pH and Henderson, Hasselbalch, and buffers, and generating a physiological-based way of thinking clinically about acid base, having an Excel program that takes care of the
quick calculations and the headaches.
So the question is this: we covered acid base. I mean, there's books written on acid base, and again, there's special topics, but we basically covered what I think is most of the important clinically relevant part of acid base in this little session here. My question is, what mistake did we make here where somebody's going to say, no, you left out a very big important thing that's very hard to understand? I've looked at this talk many times and can't come up with that. And I've looked at my patients who have these problems clinically, and this has always served me. So again, again, just to review, the things that are very important and all we talk about is, you know, steady state. If you can think of starting there, what particular steady state we're talking about, what organs are involved, what are the physiological players, are there some basic pioneering people that came up with relationships or measurements like Sorensen, and most of all, take it to the bedside or website and talk to your patient.
That is a great way to close this out. Alan, that was an awesome review. Thank you so much. For me as a clinical country nephrologist, like this is so enjoyable to go back and really dig into these topics. So I want to thank you for doing this for us and for everybody who watched here.
Well, I thank you, Craig, because as you know, I give this talk several times a day to my cat because it's in me to give, and to have a chance to tell it to somebody who's not the cat, that's great.
Awesome. Cool.
Next time we'll have something else.
Yes. Take care. Have a good one. Great job.
How long we go?
We went an hour.